Thank you. Okay, so yeah, really, like Sarah said, really great to see everybody here, and thank you for joining us. So I'm gonna talk to you today, and I really hope people don't feel like I am milking this topic too much because I have spoken about it for the past, this is the fourth year. But as Marion said, it's been such a long-running project. We've had several projects here in the UK, which we feel are some of, if not maybe even the first big examples of how end of life doula practice can work very closely alongside traditional healthcare systems here in the UK. We have the National Health Service. So today I'm going to talk to you particularly about one of those projects that we have run. I would very much like to emphasise that I am part of a much bigger team doing this work. As you'll see, that many doulas on the ground doing the work, mentors supporting them behind the scenes. And this report that we have put out, the findings I'm going to share with you today, is very much a collaboration between myself, Dr. Harriet Rademacher, who is also on the call today, Alex Deverill, and Dr. Guy Perrier. So a massive thank you to those people as well. So, as Marion said, I am one of the founders of the International Research Group, but my main work really is at the moment running End of Life Doula UK, which is the membership association in the UK for end of life doulas and end of life doulas in training. We have a really fast growing membership. We currently have around 420 members across the UK and some international members too. And our aims are kind of twofold. We support our members to practice in whatever way that looks like for them. So it's not necessarily the direct work with clients, as we're going to be talking about today, but also just sharing this knowledge in our communities, which is the ethos of our work. And as I say, today I'm going to be specifically talking about the Kingston and Richmond project, which are two boroughs in the southwest of London. You'll see as we talk through that unfortunately here the system looks completely different. Sometimes you can go down the road and it's completely different team names and different documentation that you need. So this is very much focused on those communities, and the context there is really important as well. So I want to start with a story. We like stories as doulas. They're the best way of demonstrating our work, I think. I know we talked a lot yesterday about the importance of mixed methods, which is something I'm a big proponent of. It's something that in my PhD work I use mixed methods to look at the development of death anxiety and death competency in healthcare professionals and how that interacts when they're trying to help people with advanced planning. So it's no surprise really that we use mixed methods in this methodology here. And you'll see why when you look at stories like this. So this is a bit of a composite case study, obviously with some details changed so nobody can identify themselves. So I'll just read this for you. So basically, this was a lady that we supported, one of the first referrals we had through to this project. And sadly, she'd gone into hospital after a fall, after breaking her hip. And during that operation to repair that, they had found cancer there, and she had been diagnosed with terminal cancer. And she'd become stuck in hospital, which is something that people in the UK will be sadly familiar with. There can be really big delays putting care packages in place in the community, and it can mean people, especially if they don't have friends and family to kind of fill that gap in the meantime, can be stuck in hospital for longer than they need to be, really. She didn't have family or friends nearby. And we were actually called in because the healthcare professionals thought that, rightly, understandably, she would be very worried and upset by the diagnosis she had recently received. But when we got there and met with her, her anxiety was mostly around what we would say are, the small things are actually the big things, right? So she had pets at home. She had some birds and some fish in her pond that she was very attached to. She was worried about the food going off in the fridge. It was winter. She was worried that the pipes might freeze and something might go wrong with the house. She was good friends with her neighbour, and she was worried they would think she'd just disappeared and didn't know where she'd gone. And she hadn't finalised her will, which she was now very conscious needed doing in light of her recent diagnosis. So on the very first day that the doula went to visit her in hospital, a lot of these things were able to be not completely fixed, but a lot of the anxiety was relieved. With her permission, we could immediately get her house keys, go and tell her neighbour where she was with her permission, visit her home, check everything was okay, clear out the fridge, come back to her and report back how her pets were and reassure her that we would continue to help with that. And we arranged for a solicitor to come into the hospital to visit there the same day. She did end up going into a care home with the doula's assistance. She died peacefully there a number of weeks later, and in the meantime, she'd had regular doula visits and really enjoyed spending time in the gardens with the doula. So on paper, this just emphasizes how outcome measures, which is what I'm talking about today, really don't match up with the work that we do. So if we just looked at the outcome measures here, this would not look like a positive story at all. They would be saying, well, she didn't die in her preferred place of care, which would have been at home. She had this unplanned hospital admission in her last 3 months of life, and she didn't have any advanced planning in place beyond her will. However, for Jane, it was quite a positive experience. She felt supported. She told us that she was, much less anxious. She was able to spend some really meaningful time in those last few weeks. And if we just stuck to the numbers, we wouldn't have captured any of that story, any of the reducing the anxiety or improving her isolation, the companionship, and the dignity she had at the end of her life as well. So this is why today I'm going to think with you about, well, why evaluation matters. I agree with what you said, Sarah, that it's absolutely something we need to do, but how can we do that in a way that doesn't restrict our doula practice in a way that makes it unrecognisable, really? So why does evaluation even matter? I am very aware when working with my colleagues in End of Life Doula UK that we have a really wide diversity of views about whether we should even engage with healthcare systems, whether we should even do evaluation that involves quantitative numerical data, or whether we should just stick to the stories. My personal view is that I quite like finding the in-between of these dilemmas. So I think the most helpful place is somewhere in the middle, that we can use this to our advantage. We need to recognise the system we have in the UK. I'm very mindful that this is an international group, and we'll hear later from some of our colleagues in South America. But where we are here in the UK, we have this system, this health and social care system, and we are trying to work alongside it. And many of the people that need our help most are within those settings, within those institutions, like Sarah said. So I would kind of question, if we're not willing to engage with it at all, that's a decision for us. It's not entirely person-centered. So I think we do need to try, whilst also protecting our way of working. So we know here, and I guess in many global North Westernized countries, health and social care systems, they often run on evidence and outcomes and a lot of numerical data. For commissioners to commission a service, to give funding to a service, they really need to see proof that there's value in that work, which is understandable. We don't want to be wasting that public money. They'll often need to know things like the number of people supported. Did it have an impact on reductions in hospital admission, which is one of the main things here that commissioners look for, because we're very aware of the cost that costs the system, and how that's a mismatch with the fact that most people don't want to go into hospital at the end of life as well, and the cost savings that can bring. Obviously, cost saving isn't the be all and end all, but it's something that's the most important when we're speaking to commissioners. And without having any data at all, our end-of-life doula work risks being invisible, however meaningful it is. Of course, it can still bring meaning and a lot of benefit to the people that we do reach, but it won't have any broader impact or will be recognised on a kind of higher level within systems unless we have some data to back this up. But this is a big risk for us. So as you've seen with that example just now, a lot of what we do, the holding space, the listening, the just being present with somebody, the continuity of care that we facilitate through that journey, it really doesn't translate into numbers, and it shouldn't, because that's just not life. If we try to fit ourselves into the wrong boxes, I know one of the main themes that we found in this report was square peg round hole, as Harriet named it in the themes. We risk being misunderstood or undervalued, so we have to be very careful of that. And in the worst case, the heart of our work gets completely lost. It gets boiled down to tasks completed rather than the quality of life and death that we can bring to people. And that was something that we noticed in all of the NHS projects we've done so far, that initially we were being asked questions like, okay, well, how many people can a doula have on their caseload? How many people can a doula see in a week? And it was all about kind of quantity, not quality. So we were very clear that isn't how we work. We turned down some funding that asked us to work in that way. So we were quite rightfully picky about that. And we are noticing here, sadly, that because there's so many targets within the system, that those targets are just being shifted so that the outcomes look better without it actually having a real beneficial impact on people. So a common example is here recently, if we're talking about whether somebody has advanced planning documentation in place, that has now been changed to, does somebody have an electronic advanced planning record? So it's become much more of a tick box thing. Do they have, so in my area, that's called a respect form. It gets boiled down to, does that person have a respect form, without any more of the advanced planning conversation that a doulas we know is important. Those big questions, what matters to you now, that is being lost when we're focusing on these targets. Things like preferred place of death, that's a very commonly used measure here, but we're also seeing that being changed to usual place of care, because that's kind of easier to meet, but then we've taken the person's preference out of the equation. So again, not very person-centered. And another big risk, if we focus purely on the numbers, is that we miss the experience of doulas themselves in this project, which is so important. So this at the bottom is a quote from one of the doulas that was interviewed as part of this evaluation. She said, I had a bit of tension with the ward staff on arrival, and if I hadn't been firmer with them and stood my ground, I could have easily, if that had been my first patient, I could have easily just gone, okay, I won't come in, I'll turn back. So if we just looked at, did the doula visit? Yes, they did. We would have lost all of that challenge that was there, that barrier that was there to the support. So it was really vital that we, as somebody just mentioned while we were chatting at the beginning, the participatory nature of this evaluation was vital. But I do think that done well, evaluation in this way can be a real opportunity for us. So it can give language to the difference we make. I think many of us here will be familiar with tailoring how we explain our role depending on who we're talking to. So if we're talking to other doulas here, we can throw terms around like holding space, and everybody knows what that means. If we're talking to more systems or commissioners, we may need to shift that slightly. So having these things up our sleeve is really useful to help us talk that other language to get in the door, really. And on that note, I spoke last year about the real difference it made to have an ally in the system, in the commissioning team. And to do that, you obviously need to get in there and have a sit-down conversation with people. So if nothing else, having these figures has enabled us to open those doors to collaboration, to get a seat at the table so that people are willing to hear us out. And then once you get in, we do find that if you explain how we work, it can really resonate with people. You might find that in a commissioning team, they've had a parent or a relative that's had a difficult end of life experience, and you can connect with them on a more human level when you actually get in the door. So it can definitely help us to be recognised and better resourced and better funded in this case. And as I said, it allows us to reach more people who need our support. I do think that turning completely away from the system is more about ourselves than the people that need our support. So I would kind of argue that it's important that we are willing to work closely alongside systems, not necessarily being absorbed by them. That's a different debate entirely. And here we have what's called the NHS 10-year plan, which has recently come out. So essentially anything that is being commissioned or any changes in services, any improvements, they all need to line up with whatever has been agreed as the 10-year plan here. So for us to be able to, as an organisation and individual doulas, fit along with that and to argue why we are relevant in the changing system, hopefully in the improving system, we need to be able to match ourselves up against those ambitions, really. And it helps us to understand accessibility and diversity around end-of-life doula support. So this figure you can see on the right, this is some quantitative data we collected about the number of referrals that came in from different postcodes when we did our Leeds project. And we found that the highest number of referrals came from the areas of highest economic deprivation. So that was really helpful. We were pleased about that. It meant that we were reaching people who needed the support most. And that was largely because the referrals were coming from healthcare staff who were able to spot and identify people who were most in need. So people who were very isolated, didn't have friends and family supporting them, which is a real contrast to how we work nationally, when we tend to find, I spoke last year about this, tend to find generally that the people contacting us are very able to pay for the support. So that's a reason to work closely with the system, because we can reach these people. So we need to find a way that balances the system needs with our doula values. So a few of the things that we've learned before I give you what I hope is one good solution to this problem is this is definitely stating the obvious, but it's good to have it in writing that end of life doula support really should never be measured on quantitative measures alone. It should always be at least mixed methods, and ideally it should have a really heavy focus on the qualitative side of the data, so plenty of interviews, written feedback from people who've received the support, which the doulas did throughout this project. We did have real challenges with that. So we had a really poor response rate to our survey that was asking relatives for their experience. There was lots of different reasons for that. People were being surveyed by other services, so there was quite a heavy survey burden on people. That would also have missed a big part of the story if we just focused on hearing from people who'd received the support. We wouldn't have heard the doula's experience, we wouldn't have heard the mentor's experience, and a lot of what we learned came from those people about what worked and what didn't. So it was really important that we did those interviews and we included healthcare professionals in those as well. So again, this is very much about participatory evaluation, inviting everybody, all stakeholders, everybody involved to help us define what good doula support means. We're not telling people what that means, they're telling us. So I'm going to talk to you today about one potential, well, we certainly felt it worked well and something that other people might consider using for their project evaluation when it comes to doulas. So for this evaluation for Kingston Richmond, we use something called contribution analysis. You might have heard of it, but if not, I'll explain what it is. So it essentially focuses on the fact that there is a huge problem, and anyone in academia will know this, with these overstated claims of causation. So even if doulas are in the community doing a great job, having a really positive impact, we cannot say that we are the only factor there. It's not a direct causal relationship. Having a doula has had all of this positive impact and there's been no other factors involved. Attempting that linear causal association is just not the right thing to do, because if you can imagine that first example, there's the doula there, there's all the healthcare professionals supporting as well. There's personal individual factors, like as a psychologist, my background, you'd be thinking about the person's own coping strategies and their own resilience. And there's just too many factors for us to attempt. And again, we know that too many, I think, services do attempt to give this causal association. So we were very upfront in acknowledging that that was not feasible, reliable, or meaningful in this situation. And what contribution analysis allows for is a much more nuanced evaluation. Anyone who's heard me talk before knows that I really favour the middle between the intersecting tensions and thinking about can we unpack that nuance and have a more sort of humble approach to it, whilst also being able to ask this really important question. So we were essentially asking through contribution analysis, what difference did end-of-life doulas plausibly make within the bigger system? And that's what contribution analysis does. It looks for, did we make a difference? And that, I think, was really helpful, because if you go back to the commissioners and the healthcare system, everybody might be coming at it from a different angle, but essentially we can all unite around that question. Everybody ultimately wants to know, did this make a positive difference? So by using contribution analysis, it made it, our outcomes were credible to the system, but it avoided overclaiming, and it also did what felt like a very doula-y human thing, which was to honour human complexity. Because in this example at the bottom, we can't prove that a family carer coped better because of the doula, but we can show how doula support contributed alongside other things, clinical care, support networks, etc. So what did this actually look like? So before the project, we brought together all of the doulas on the project and some of the project mentors too, and we used this outcome framework from an organisation called Matter of Focus, which I'll show you in a minute. And we essentially said, okay, well, we're not going to tell you what we're going to measure you on. We want us all to come up with this together, that collaborative approach. So we asked people what they were worried about, what barriers they were foreseeing from maybe doula practice they'd done in the past, or maybe they were new to this. What did they think would help them and facilitate their practice? What did they need as individuals? What did we need from each other? Some kind of like group rules within the project. And we also used this individual social material tool, which was developed by the Scottish Government. which helps us to explore the context of the doula role within those three contexts. So helping doulas think, what do I have within myself and in my own life that's going to enable or hinder me in this role? What about the social context and what about the material context? And these tools and contribution analysis, we knew from looking how they'd been used in the past, were really relevant, because I know we've got lots of Canadian colleagues here. So contribution analysis originally came from looking at public health approaches in Canada. And since then, it's been used in essentially any human project where there's lots of factors. It's been used in Africa, looking at agricultural projects and things. So this, along with the ISM model and the outcome framework, were the tools that we used to look at risks, assumptions, and enablers. So we co-designed and agreed this outcome map, which I'm going to show you in a second. It looks a bit overwhelming, but I'll talk through it. And then during the project, End of Life Doulas collected quantitative outcome measures. So we did still do the numerical side of things. They also asked relatives and the people they were supporting for feedback. If they received like a thank you card, they asked if they could use that within the evaluation as well. So we had a lot of written data too. And then after the project, Harriet and Alex did a lot of work sitting down with and interviewing the doulas, the project mentors, managers, and healthcare professionals who were involved. So it was a huge job really, but it came out with something that again looks a bit complicated, but I will talk through it. So this is using the individual social material model. And you can see there the things at the bottom are things that doulas named as being helpful things within each of these realms for their practice. And at the top, they were unhelpful things that they thought would be barriers. Now you can see if I start with the material, I won't read through them all, don't worry. But there was things that we were all very aware of that were falling down in the system. We've got a very stretched healthcare system here. We're all very familiar with our own care, difficulties getting GP appointments, being able to contact people, being able to work flexibly, and other things, technological barriers. They're shared records that we're not allowed access to for data protection laws and things. So we were quite conscious that however keen we were to make this work, there were going to be those things that were in our way, essentially. Although we did find some really good ways around those things. And then in terms of social settings, so we've talked a lot in these symposiums about, and I know in the Delphi study results, one of the things people are interested in is healthcare professionals' experiences of working with doulas. This fact that when we first approach people, they might feel threatened by our role. They might just shut the door on us completely. So again, however well-meaning we were very aware that we might not be welcome in these spaces, and that was going to have an impact on doulas and in terms of, their self-care as well. It can be really draining. Reluctance from clients. One of the things we found was that some people just didn't like the fact that we had end of life in our name and we couldn't do anything about that. Maybe they weren't in a place to acknowledge that they were at the end of life. And that's fine. We have to meet people where they are. Misunderstandings around cultural differences, support from other care systems, accountability to each other was a nice one. And then individual. So a lot of this was around personal confidence, resilience, self-care, lack of knowledge of NHS systems, feeling overwhelmed by the system. And I think, I hope for the doulas in the project, that was a really refreshing space just to be able to share those things and to hear that other people were worried about them as well. And then this was the outcome framework we use, which I really love. It felt all of a sudden when I saw it like an outcome measure that was actually human and really fitted with our doula work. So these are the 6 questions that we structured the report around this, and this is what we were looking at in our evaluation. So what do we do? I know that's a big question. We were talking yesterday about how I definitely find it frustrating when you go and read some studies on end-of-life doulas and it kind of falls down in the first paragraph because people say something like, there's no agreed thing that what end-of-life doulas actually do, as if we don't know what we do. So writing those things down, before and after the project. So what is it we think we do? What are the tasks we help people with? Advanced planning. And then after the project, asking what is it we did? What did the support look like? Is that very different to what we expected? One of the things on the Leeds project I talked about was being asked to do things we'd never been asked to do before, like can you rent a van and help people move house? We'd never done it before, but when we thought about it, there wasn't actually a reason we couldn't, as long as the doula was happy to do that. Who did we do that with? So obviously the person, usually their relatives, but all of the other services that we kind of had touch points with, so the GP, other doulas working on a team, like Sarah said, which came with its own challenges sometimes. And how do people feel? Really liked that question. So after having that interaction with the doula, how do they go away feeling? Healthcare professionals said that they felt reassured, like some of the weight and pressure had been taken off their role. How did the people who received support feel? Obviously, most importantly, how did doulas feel when they walked out of somewhere? And what support did they need? And then what did they learn and gain from the experience? So this is all about our End of Life Doula UK logo is a ripple for this reason, because we like to think that everything we do helps build death literacy, death competency in our communities. So we wanted to know what impact did that have beyond the initial interaction with the doula? What did people learn? What did they then go and do that they weren't confident enough to do before? Common examples were, well, A, they were likely to refer or recommend a doula to somebody else, but it also meant that they felt more empowered to do their own advanced planning. So some relatives said that they felt more able to do that for themselves now they'd seen their relative do it. What did they do differently? So what behaviour changed? What practices changed? We saw certainly some healthcare professionals we worked with closely, they changed their practice and were more open to sort of community approaches to end-of-life care, which is what we're all about. And ultimately, what difference does it make? So again, that's the question we're all uniting around to find out what's the ultimate benefit. So I did consider cutting this slide down, but I couldn't decide what to take out of it. And I also wanted to emphasize, like, this is the range of findings that we came up with. So please don't feel like you need to read through all this. But these are those 6 questions split into the findings that came from all of those people that we interviewed, basically. So there wasn't much surprising in what we did, I guess. It was things like advanced planning that we knew doulas did. It was a mix of practical, emotional, spiritual support, raising awareness in local communities. So there wasn't many surprises there, but it was good to kind of have it down and clear that this is what we were doing. Who with? So I think we were pleasantly surprised that that was a broader range that we were anticipating. We did work with a lot of like neighbourhood teams, family carer charities, they started referring to us as well, local hospices. So that was quite a broad reach in terms of collaboration. Other end-of-life doulas, really important. I think that's something, I know, Sarah, your talk last year was very much about the benefits of that for our own self-care. And again, that wasn't without challenges. I think as doulas, one of the things we can do is bring our own approach to the role, but sometimes that can mean we can clash with other doulas, understandably. So that was something that we did notice. How did people feel? So again, we would hope and expect people felt supported, but people felt less stressed. They felt more connected. Doulas themselves felt more connected. Everybody felt like they were part of a more stronger collaborative care network. The healthcare professional told us that as well. People learned and gained skills around just knowing what to do at the end of life, that basic human knowledge that we feel everybody should have. New knowledge and knowing what doulas do for a start. We found at the start of the project that sometimes healthcare professionals would describe us as companions or sometimes counsellors, which was very unhelpful. But that was because they didn't understand fully what we did. So over time, they did have a much better understanding of our work. And then for me, the most interesting ones were what people did differently and what difference did that make. So people felt much more equipped to die outside of hospital. Great, that's a win-win for everybody, thinking about those cost benefits as well at the start, avoiding unnecessary hospital visits. Doulas really enjoyed working on a collaborative project. Families felt much more able to engage in legacy work and their own advanced planning. And people generally had a better experience. We did do that qualitative data analysis as well and found that hospital admission seemed to be very, very low. In fact, I don't think anybody we supported had an emergency hospital admission in the last 3 months, which was a big difference. It enhanced social cohesion, and ultimately, services wanted to have an ongoing relationship with end-of-life doulas beyond the end of the project, which was great. So, key messages to take away: we definitely need evaluation approaches. We definitely need ones that enable us to speak to these systems without erasing our work. We must not be afraid to say no if we're being asked to bend and twist ourselves to fit these outcome measures, which completely miss and sometimes, worst case, totally undervalue what we do. We need this if we want to build credibility and visibility, essentially. It's something that we found as an organisation since we've done these NHS projects. We're much more likely to get contacted by other healthcare professionals who want to teach each other about what we do, being invited at universities to speak to trainee doctors and nurses, for example, and get the word out that way. And I would really recommend contribution analysis as a tried and tested option for others that are looking to evaluate similar projects.